And on behalf of CME Outfitters, I would like to thank you for joining us for today's educational activity titled A Hot Potato in Healthcare. Whose responsibility is it to advocate for cancer screening for SGM patients? This activity is brought to you by CME Outfitters, an award-winning accredited provider of continuing education for clinicians worldwide. And it is supported by an educational grant from Merck Sharp and Domi Corp. Again, I am Don Dizon. I am a professor of medicine and professor of surgery here at Brown University, and I direct the pelvic malignancies program and hematology oncology outpatient clinics at Lifespan Cancer Institute. I also head the Office of Community Outreach and Engagement at the Legaretta Cancer Center at Brown University, and direct medical oncology and the oncology sexual health first responders program at Rhode Island Hospital here in Providence. I am gratefully joined by Dr. Gwendolyn Quinn, professor, and the Livia Wan, MD, endowed chair in the Department of Obstetrics and Gynecology at the New York University Grossman School of Medicine in New York, New York. Welcome, Dr. Quinn.
Thank you, Dr. Dizon. I look forward to talking with you today.
Me too. So let's start by reviewing our learning objective for today's session. After participating in today's activity, clinicians should be better able to identify techniques for providing culturally relevant communications regarding cancer screening, particularly as it relates to sexual and gender minoritized people, also known as SGM. Before we jump in, let's take a minute to review some of the concepts and terms that we will use in today's discussion so that we are all on the same page. What's important to understand is that sex assigned at birth and gender are often mistakenly used interchangeably and inappropriately. And it's used sometimes to assume anatomy. It's important to understand that sex at its most basic is a biological construct, but gender is actually a social construct. So they shouldn't be conflated as synonymous. And with that, why don't I hand it over to Dr. Quinn?
Thank you. So to follow up on what you said, it is important to separate sexual orientation, which is someone's attraction to other people, versus their gender identity, which is how they see themselves, regardless of how they were assigned at birth. So recognizing that sexual and gender minorities, or SGM, or what also may be called LGBTQ+, is a population that experiences health disparities. And it was deemed so by the National Institutes of Health and the American Society of Clinical Oncology. Most of the literature that we know about sexual and gender minorities in cancer care focuses on risk factors, the poor outcomes experienced by this community, or experiences specific to HIV/AIDS, which is not relevant for everyone who identifies as SGM. So communication skills are really needed by clinicians who are caring for sexual and gender minority patients, because oftentimes that status is not always visible. And the reason it's not visible is a lot of practice settings don't have the opportunity to collect what we call SOGI, which is sexual orientation and gender identity data. And this is kind of a two-way street. So some clinicians are not sure why they need to know SOGI, and some patients are not sure why they should disclose that to a patient. However, we know that it is very important on both levels, and we're certainly working to educate healthcare professionals about why SOGI, knowing the SOGI status of their SGM patients, or actually of all patients, is important. Prior research has shown that some healthcare professionals have limited knowledge of the unique needs of SGM patients. And fortunately, very few, but they do exist, have negative attitudes also. So some of the barriers for SGM people to seek care, and the reason why they might present for care at later stages of disease, is they're often less likely to have health insurance. And so they may be foregoing routine care to pay for other costs in their household. Also, for transgender and non-binary people specifically, many insurance companies don't cover mental health services. And some of those gender affirming care services require having mental health coverage in order to receive hormonal therapy or gender affirming surgery. The other thing that we know from the literature is that sexual and gender minority patients may be likely to remain silent about something that's important to them because they may fear being stigmatized in the healthcare setting or even refused care if they disclose their sexual orientation or gender identity. And of course, because of prior stigmatization about people from the LGBTQ plus community, there might be lack of trust and understanding, and there might not be good patient physician relationships. Also, patients may be afraid that not only will they receive worse care or substandard care if they disclose their sexual orientation or gender identity, but they may also worry that if they tell this in a healthcare setting or to a provider, who else might have access to this information and how can it be kept confidential if that's what they would like. And also we know from research with this community that many feel that they don't have access to culturally sensitive resources, people who are familiar with sexual and gender minorities, and they have limited ways to get referrals for mental health counseling, sexual health counseling, and even fertility planning in ways that are tailored to them.
So Gwendolyn, let me just ask you, I'm going to interrupt you right here because I think it's so fascinating. When we talk about SGM people or LGBTQIA members, one of the things that I think sometimes happen is we as clinicians will ask about it when it's obvious that someone doesn't fit into what that model of what a male or female, woman or man should be. But there's this whole other group of people, including in the trans community, who pass sort of, I just learned the term, they're stealth, so they can actually slip into care and no one questions their gender. So I do think it's a really important concept that you brought up in the very beginning of your talk about how we need to ask these questions of everybody.
That's right. And I imagine, as we've seen in our own hospital, as we're trying to incorporate collecting SOGI data from everyone, that if you've seen a patient for 20 years and now you're asking them about their sexual orientation or their gender identity, their eyebrows are going to be raised a little bit about, why are you asking this? You've delivered my children. You know a lot about me. But we really have to work to normalize that this is part of routine care for everyone, and also be mindful that both sexual orientation and gender identity can be fluid. And there's nothing wrong with that. And so that's why it's important to ask at every visit, or at least every year, to see, just like we ask if there's been any change in health status, any change in medications, particularly with younger populations, we should ask if there are, changes in sexual orientation or gender identity.
Yeah, I think that's really critical. I just, it's as if when we see patients, we fix them in time when we first meet them. So if you were married when I first met you, you are forever married, which we know is not the case. And I think for the audience, it's so critical to understand that people can rediscover, redefine themselves at any point. So making this a sort of a living question, not static, I think is really critical. Thanks for that.
Yeah, that's a really great point to underscore, that not just sexual orientation, gender identity, but many aspects of our lives, from our address to our partner status, may change. And no one likes to answer the same question over and over again, but it is really important that we normalize to ask this of everybody and not judge anyone based on how they look or how we think they fit in. And so we're going to focus more today on cervical and breast or chest screenings. But some of the strategies that we're talking about today to engage patients can be applied to routine screenings and all health-related discussions. And so we know that mammography and cervical screenings can be life-saving, but we also know that very high numbers of sexual and gender minority patients are not receiving these screenings. And these are for many reasons, from not having access, not knowing that they need them, or this event being triggering to them because perhaps they don't identify with these parts of their body. So a recent study assessed that the perceptions of and barriers to cancer screening said that in more than 50% of sexual and gender minority patients, they reported some form of emotional distress as the reason for not receiving the routine cancer screenings. And I think all of us can identify that, even if we're cisgender and heterosexual, that most of us don't love, doing these things, but we do love the peace of mind that we get of crossing them off our list. And also the idea that if we get them routinely, as directed by national guidelines, if something is found, the earlier it's found, the more likely for a better outcome.
So, Dr. Quinn, just a question that comes up, rarely, but it's something for everyone to consider, that even after, say, a trans man has had chest surgery, it is not synonymous with the removal of all breast tissue. And I don't know if that's something you want to comment on as well. It actually complicates the conversation, I think.
Yeah, I think it does. I think it's similar to a cisgender woman who has had, mastectomy for perhaps being a BRCA, unaffected carrier. There possibly always is some remaining breast tissue that may need to be, or chest tissue that may need to be screened. And I know that WPATH, the World Professional Association for Transgender Health, is coming out with some updated guidelines with regard to that, and the amount of years and how often the screening should occur. But it is important for everyone, whether you're due for a screening, you don't think you need one, that if you ever notice any changes, lumps or pain, rash or redness in that area, that you do see a physician to get it checked out. And so to kind of circle back about the emotional stress as a reason for not receiving routine cancer screenings, there's a lot of reasons why this may be distressful, other than just having fear of the white coat. Some of it is about whether or not a practice or practitioners in a practice seem welcoming. So a lot of the language that we use, particularly about mammography and cervical cancer screening, is gendered. We talk about breast instead of chest. We talk about a women's health clinic. We talk about women's pap smear. And so if you don't identify as a woman, but still have a cervix or have tissue that should be examined, you may say, well, this place that's advertising like this, that's not for me. That doesn't sit right with me. We also hopefully are changing in the years to come, but right now the majority of our electronic health records or our electronic medical systems have boxes that are exclusive of diverse genders, and in some cases may even have a skip pattern. So if you put down your identity as a woman, you'll only get questions about menstrual cycles and pregnancies and things like that. You may be a trans woman, and so those questions will not apply to you. So I think that we're hoping in the future to move more towards organ inventories, but for now, those intake forms might not give the practice or the physician the opportunity to really drill into what types of screenings this patient may need. Also, there may be things that may ask about marital questions instead of using the word partner. We may not be asking patients for their pronouns or what names they like to be called as opposed to what their legal names are. All of these things may send a message to a patient that this is not a welcoming place to be. Sometimes in the ICU, for example, we say that only spouses or the parents of the patient can access the patient. And that may not be patient's support person. They may not have a spouse, they may have a partner, they may have other people that are their chosen family. And so I think that we should really focus on, creating inclusive language, creating multiple opportunities to ask patients to give us this information, and also to show that when we receive this information, that it matters. If a cisgender woman tells us that she identifies as a lesbian and she only has sex with women, we shouldn't ask her to take a pregnancy test unless we explain that it's required by insurance company for everyone with a uterus, right, regardless of whether they're sexually active or not. So we take the extra step to show that we heard this information, and we tailor what we say based on that information. I think another thing that may be a deterrent for people using preventative care is that they're used to going to the doctors and being asked if they smoke, and they say yes, and they get a long lecture about smoking behavior, or they ask how many drinks a day they have, and they get a lecture about that. It's certainly important to address those things, but it shouldn't be the focus, at least at the first time a patient's coming for care, or they're not likely to come back. In addition to the language, there are ways to make the environment look welcoming. It's not enough to just put a rainbow sticker in the window or have rainbow flags visible in the office. It's really important that everybody, from the person who answers the phone to the receptionist, that everyone has been trained in how to be inclusive in language and actions. There are ways that we send messages to patients. So for example, in most mammography units, the gowns are pink or they are floral. And that is probably not very welcoming to a person who identifies as a man. And even a cisgender man from time to time may need mammography. Although breast cancer is rare in cisgender men, it still does happen. And it certainly doesn't feel inclusive with all of that pink. Also, if we have patient education materials, if we say, for example, what to expect when you get a pap test, and there's a white man and a woman on the cover, it's not inclusive to people for a variety of reasons. They may not identify with that race and ethnicity. They may not have that type of relationship. And so we really need to think about patient-facing information and what it looks like in ways that are inclusive, including what magazines we have in the waiting room. If we have Vogue and only fashion magazines, it could seem very much like this is a place for cisgender women. And also taking into consideration that on our websites and in the emails that we write, that the language is really tailored to use appropriate pronouns. And when we don't know which ones to use, we're always better off, if we can't ask, such as in an email, saying they and them, or using other inclusive language.
I think, the major takeaways that I'm getting from Dr. Quinn is really how important it is that we don't assume. We don't assume a sexual orientation. We also don't assume a gender, because even those folks who look like us may not actually identify as we do. And that's a really important thing to understand. But at the end of the day, Dr. Quinn, we can educate our staff, we can educate our colleagues about language, we can, adopt uniformly about pronouns, we can, change our environments to be more welcoming to both sexual minorities, but also to the transgender community, in whom, you're talking about a very diverse group within a community. And to assume that the healthcare needs and also the experience of lesbians is the same as that of gay men, is the same as that of transgender men, is the same as that of transgender women, would be a mistake. Even if we did all of that, I think one of the things I worry about, and I actually talk about this around this issue, is there are some assumptions that are made by both the patient, but also by the provider, that can stand in the way of screening. And it sort of begs the question then, whose responsibility, right, is it to ask for the screening? I like to think that today patients are exceptionally engaged in their healthcare, that they can advocate for their care. But in reality, that's not the most common experiences. And when you're talking about a group of people who have faced varying degrees of hostility in medical systems, it's not terribly likely that they're going to provoke a conversation, engage in debate, or God forbid, argue. But at the end, we need to make sure that everyone is on the same pages about what screening is required. And it was very interesting that there was a survey administered via social media that it included sexual and gender minoritized people, and over 65% were not clear about what screening they should do for themselves. And this kind of makes sense. One of the bigger issues that I've run into, when discussing pap smears for someone who was treated for breast cancer who's a lesbian, I don't need it because I don't sleep with men. Now, I don't know where that came from, whether in her past a doc told her that, and it's something that she felt makes sense to me. But in reality, you don't have to be having heterosexual sex to be at risk for HPV. So I think we are dealing with a knowledge issue and a comfort issue, and all of it, comes together. But on the lines of whose responsibility it is to engage in conversations around cancer screening, and as you mentioned with smoking and these preventative health measures, why don't we jump into a patient case? We'll talk with Stephanie, who's 48 years old, identifies as female, and she's presenting via telehealth video for follow-up after being diagnosed with hypertension and starting new medications for that. Let's see if you can spot the ways that our provider, in this case it's Dr. Quinn, engages the patient in advocating for her health.
Hi, Stephanie. I'm Dr. Quinn, and my pronouns are she, her. What are your pronouns?
I guess she, her. What? Why does that matter? And I go by Steph.
Oh, thanks for telling me your preferred name. We ask about pronouns because we want to be respectful of your identities and of you as a whole person.
Weird, but okay.
Okay, Steph. First, I want to make sure that you're in a private place for this visit. We're all pros at technology now because of the pandemic, but are you okay to continue?
Yes, I'm at home by myself.
Okay. And I also want to let you know that I'll be at times looking at your chart. So it may seem like I'm not looking at you in the camera, but I'm looking over here at your chart. So as I'm looking through your chart, I think we missed getting a lot of information from you. I can follow up with some of that later. But when you were last here, you were having headaches and your blood pressure was pretty high. Have your headaches improved since you started the blood pressure medication?
Yeah, they've pretty much gone away. I think the medicine's helping. I sometimes forget to take the medicine every day, but I'm getting the hang of it. So.
Okay. Steph, do you live alone or with a partner or roommates?
What does that have to do with my blood pressure?
I know that may seem kind of off, but it's important that I get to know the whole you to provide the best care. So I was going to make a suggestion if you live with a partner.
Yes, I live with a partner. What's the suggestion?
Well, maybe sometimes it's helpful if our partners remind us with daily medications. What do you think about that?
Yeah, maybe so.
Okay. We also talked about keeping a daily blood pressure log. Do you have it with you now so we can talk about how well the new medication is working?
Yeah, I've been keeping up with it. I forget sometimes, but I remember to write it down most days. It seems like almost every day it's under 135 now. And I already loaded it into the patient portal.
Oh, okay. Yes. I see it here now. It does look like your readings are better, and I'm glad you're responding so well to the medication. Are you having any side effects or problems with the medication that we should talk about?
No, I really feel a lot better since I've been on it. The pharmacist said I'm maybe lightheaded at first, but I haven't had any trouble at all.
Okay, that's great. Steph, since you aren't having any side effects and it's working well, I want you to continue taking the medication.
Okay, that's a relief. I don't want to have to come back in for another visit.
I hear you, and it's great that your current health is good, but I'd like to take a couple minutes to talk to you about future health that I talk about with all my patients. So if you don't mind, let's fill in a few missing pieces of your chart. So first, tell me, do you smoke cigarettes or use vape products?
Nope. I'm glad I never started that.
I'm glad for you too. Okay, then when was your last pap test?
Hey, I'm just here for a follow-up.
Yeah, I understand. Some of these questions might seem personal and they might not seem like they go together well, but I want to assure you that I'm asking these questions so I can have a better idea of which routine screenings you might need. And so I can make sure we're taking care of all of your health needs, not just your blood pressure. So
I'm sorry, I thought I didn't need PAPs anymore. I don't have sex with men.
yeah, I think that's a common misperception. So every person with a cervix needs PAPs. It doesn't matter who they have sex with. It's a very important part of preventive care. And depending upon the results and your age, you may only need one every 3 years and maybe even every 5 years.
Wow, I think I had one in my 20s. I can't remember, honestly. I thought I didn't need them.
Okay, well, we'll circle back to that. What about a mammogram? Have you had one?
Oh no, I don't need that. There's no breast cancer in my family.
I think that's another common myth. Everyone with breast tissue needs a mammogram. Most people who were born male may not ever need one, and people who have had a mastectomy may not need one, but the rest of us do.
Wow, that's news to me. I thought you only needed it if you had a family history, and there's no cancer in my family. We just have heart disease.
Yeah, I think most people don't realize that really only less than 10% of cancers are hereditary or based on a family history. The majority are sporadic, meaning, they just occur. So if you did have a strong family history, that could increase your need for screening and for the timing of your mammogram screening. But all humans need some form of preventive cancer screening.
I guess I should tell my girlfriend about the PAPs and the mammograms. If you haven't figured out by now, my partner's a woman, but I don't tell many people I have a girlfriend. I bet you don't see many of us in this little town.
I'm so glad that you felt like this was a safe space to disclose that to me. You might be surprised to know that you're not my only queer patient.
Oh, hang in there. Who said anything about queer? What are you talking about?
I'm sorry, my apologies. I should have asked how you identify. Queer can be an umbrella term that some people identify with if they're LGBTQ, and to other people it's offensive. And so I should have asked how you identify.
I think of myself as a gay woman, but I don't talk about it to too many people.
So there is a place in your medical chart for me to document your sexual orientation. Would you like it in there?
Why does it matter?
Well, hopefully in the future, if this is, excuse me, documented in your account, we can tailor your discussions for this. So for example, it may prevent future people in the clinic from asking you about birth control, which is of course different than safer sex practices. And now that I know that you live with a romantic partner, I may ask other questions to make sure you have the social support that you need and that you're safe. So in your next visit, we can talk about other cancer screenings so they don't come as a surprise to you. So while getting older is great, it also comes with the need for a colonoscopy and fecal occult blood test for colon cancer.
Geez, I don't know if I don't I don't know if I want that in my chart. Can I think about it?
Sure, sure.
Also, I don't I don't really like going to the doctor. No offense, but my motto has always been if it's not broken, don't fix it.
Yeah, I hear you. I feel the same way about the dentist. But also, like the dentist, cancer screenings are important because if we catch things early, excuse me, particularly cancer, the chance for a cure is much better. So often by the time there are symptoms or broken things or things that we notice with our body that are out of whack, the cancer could be at a later stage, which is why these cancer screenings are based on your family history, your own personal history, as well as your chronologic age.
Mm. Well, can I do the paps and mammograms by video?
I hope that maybe someday we'll have that technology, but as of today, you need to come in for the special instruments that we use, and we have to physically examine you. But let's try to schedule those pap and mammogram testing soon. And if you want, maybe you and your girlfriend can come together. I'd be happy to see both of you. What's your partner's name?
Her name is Michelle, and yeah, I'll try to get her to come with me.
Great, thank you. It was so nice to meet with you today, and I look forward to seeing you and Michelle again in the future.
Thank you.
So as we just saw in that video, patients have different perceptions of their own risk for cancer, and not all sexual and gender minority patients have the same risk. So since our patient today identified as a lesbian woman, let's look at some of the behaviors that we know from the literature. And again, these are generalizations. They are not true of every person who identifies as a lesbian, but some of these behaviors may lead to increased risk of cancer, especially for patients who avoid or delay care. So I will also add that the majority of these, what we're going to call risky behaviors, are associated with stress and stigma. And anybody who felt part of a marginalized community in this country is likely to also use these behaviors as coping behaviors. So it's not just because someone is attracted to women that these behaviors automatically coincide with it. So there tends to be higher rates of smoking in women who identify as queer, lesbian, gay, compared to straight women. There's also different perceptions of ideal body type. So straight women tend to be looking for thinner, figures, look to people in the movies and other celebrities with ideal body types. That can be less so true in this population of women. So they can tend to have a higher BMI, especially if they live in rural areas, which might be true of everyone who lives in a rural area, regardless of their sexual orientation, but they might not have access to the ability, to exercise, especially in cold weather. They might not have access to fruits and vegetables. There tends to be higher rates of depression in this population, which is definitely related to the stigma that society can place on people who identify as such. Higher rates of alcohol use, higher rates of substance use, lower rates of organ-appropriate cancer screening. And we've talked about some of the reasons why that might be, and we'll talk about it a little bit more. And also lower rates or less likely to have a child. And this is important because childbearing or giving birth, pregnancy, it actually can reduce women's risk sometimes for breast cancer and other types of cancer. It's not a guarantee, but it is an epidemiological associated factor with increased risk for a person who has never had a child, a person with a uterus who has never had a child.
Yeah, so Dr. Quinn, I think it's really important that anyone listening understands exactly how you phrase it, that these are behaviors associated with an increased risk. This never explains why someone got cancer, right? So, looking at a queer woman who has breast cancer and then assuming that they were smokers is never something we do in the general population. And certainly none of these factors should be used to stigmatize a group who's already feeling and facing stigma in healthcare.
Yeah, I agree. And I think also, for example, with the higher BMI, it's important to understand that while we might be more attracted to a certain body type, or there's a body type that we like to have, it can mean something for our health. But we can also, as you know, not just go by the clinical BMI. There's many other factors that would let us know, if this person's weight is a potential problem. And it's not enough to just say to someone, you need to lose weight, but to examine, what it is that they're doing, what things make sense for them to make changes in their life. If they have mobility issues, we cannot tell them to walk to work or take the stairs. So
Mhm.
these are just, guideposts that raise a red flag for us to potentially ask more questions, find out more about our patient and how we can best help them.
Right. And I think at the end of the day, this is about preventing cancer and the steps that we as clinicians can do to prevent it. Coming in, someone seeing me as an oncologist after they've been diagnosed, it serves no role for me to say, well, if you had just lost weight, or well, if you had just had children. I mean, some of these things are not things that, are necessarily under our control, but it serves no role after the fact. But before, if we want to do everything, if this person is motivated to reduce their risk, these are the things that we can do because they're modifiable.
Mhm. Right. And in working with lung cancer patients, for example, people always ask them, oh, did you smoke? And there are many people who get lung cancer who either quit smoking a long time ago or never smoked. And they often say, when you hear someone had a heart attack, you don't go up to them and say, do you eat a lot of red meat? So I think sometimes society is looking to blame people for, their behavior, but I think they're also looking to excuse and say, well, this will be okay because I don't eat red meat, so I won't have a heart attack.
I agree with you there.
And so that kind of takes us back to this hot potato in healthcare about whether or not clinicians need to be telling people about what cancer screenings they should have, or whether patients should be asking for it. And so there's a lot of reasons why all people, not just sexual and gender minority people, don't go to the doctor. As we heard Stephanie say, in They Encounter, many people have if it's not broken, it doesn't need to be fixed. So if I'm feeling okay, why would I go to the doctor? Also, there's myths and misperceptions in the community. Many people, not just gay women, think that if there's no family history of breast cancer, then they themselves are not at risk for cancer. So I don't think it's incumbent upon patients to have to ask for what we know that they should have. I think we also should be prepared. For example, if we were, Stephanie's not yet the right age, but we could prepare her for potentially a colonoscopy. And if she were to say she didn't want to do that, we don't just end the door on that conversation. So there's other options, the Cologuard, FOBT, IFOBT testing. So we can explain that it's not the ideal, it's not the gold standard, but there might be ways to help people through getting some form of cancer screening if they decline what's being offered to them. So we have this opportunity to engage our patients to find out what are their goals, what are their concerns, and to make the care that we give relevant to them. And maybe we can talk about some of the strategies that might have been successful or that could have been better in this patient encounter with Stephanie.
Right. I think if you think about how just from time zero, how we introduce ourselves to people can make all the difference in the world. And one thing that was done here was how Dr. Quinn, you introduced yourself. And it really emphasized the importance of pronouns.
Yeah, I find that is a great icebreaker. Before I have to ask the patient, I always give my own. It is kind of unusual for some patients to hear that. But as we said in the beginning, I think in the years to come, hopefully it'll become normalized.
Yeah, and I think, when I've done it, I will be the first to admit it's not something that I do all the time. I'm still in the process of trying to really relearn how to introduce myself to everybody. And I think Dr. Quinn, you had mentioned in the very beginning, it is this issue of if you've seen somebody for several years to then come in and say, oh, I should let you know my pronouns are he, him, his, may not feel very natural, not only to you, but to the person you're seeing. But we do need to start somewhere. And we need to get into the comfort level of delivering our pronouns. I think one of the things sometimes I hear, though, Dr. Quinn, maybe it's a point to comment on, people are afraid of the reaction that they might get once they deliver pronouns and ask for, someone else's. And like you said, it may be weird to some people, particularly in the general population, in whom I like to think everybody's heard of pronouns, but that is not the case. And so I think people prepare themselves for having to explain it. And a lot of our colleagues feel, I really just don't want to have to deal with that.
Yeah, I think, definitely. But I think I know I do, I have anticipatory concerns that are probably greater than the reality. So the reality is a very small minority of people might actually get angry about this. Most people are going to be curious, and it's a good opportunity to explain, our hospital, our clinic is changing to a new system. We want to be inclusive. We want to be respectful. So we're asking everyone. We may ask you at other points of time and care. So I think, and I will tell you that I watched a resident interacting with a patient and asked for pronouns. And this person was in their late 70s, and they were so thrilled. They said, no one has ever asked me, and I've never had an opportunity to disclose. So for every potentially negative experience you might have while asking for pronouns, there's going to be those also moments of joy that people are being seen and given the opportunity to be seen.
The one thing that always sticks in my mind is the power of being seen. When you're sitting with a patient and you allow them the space to declare who they are, and then because pronouns have no assumption about sexual orientation, but once you get that, once you person is in a place where they feel safe, and maybe we can talk about sort of safe spaces, safe where they can disclose and tell you who they are, the sense of relief is palpable.
Mm-hmm. Yes, for sure. And I'm also finding that there are some people who don't prefer to have any pronouns, and it has been a learning curve for me to just use their name all the time. But as with anything, if I make a mistake, I ask my patients to correct me and let me know. If I catch the mistake on my own, I just apologize and move on. Try not to make a huge deal about it. Not say, oh my gosh, I'm so sorry, which just calls further attention to it. So we will make mistakes, and that's okay, because we are all human.
And I think people are generous enough to understand that people are learning. And in a lot of ways, it's a process that people are willing to walk with you as a clinician because they know you're trying to be inclusive.
That's true. And even if your patient, is older and very ensconced in their own identity and orientation, they may have children or grandchildren. And so they also may appreciate the affirmingness of the clinic that's asking these questions, even to cisgender and heterosexual people.
So, Dr. Quinn, I think one of the other concerns that plays out here is this, the concept of fear of, you might be the person who welcomes them in and is able to, give them that space to disclose, to really talk about who they are, their sexual orientation and gender. But in a lot of ways, cancer care, primary care, it's a team effort. So you're not the one doing the mammogram. In fact, the radiologist reading isn't the tech that's performing the procedure. God forbid, Stephanie needs a surgeon. So there's multiple points where the process repeats,
Mhm.
and I think that is one of the fears that I've seen play out, that it's better not to ask because I just can't. It's like you use the word triggering. It can be triggering to have to go through this. I imagine a trans female who still has her prostate, getting prostate cancer, having subject themselves to an exam of a body part that they don't identify with, and not only with one physician, but multiple physicians may be involved. So, how does one prepare for that patient for that entry into the system rather than into your office?
Yeah, I'm curious to hear what you think about that. I would say, in some systems, we know if we have the ability, we know who to refer them to and who not to in that system.
Mhm.
Try to get them into people that we know are, can provide culturally tailored care. I also think we can prepare the patient, especially if we cannot control any of that, and say, you might be asked this question, you might have to explain this for yourself. I often ask, is there somebody who can accompany you to these visits, who can advocate for you during this
Yeah.
time? Because it's exhausting to not feel well and then to have to be triggered or stigmatized answering these questions over and over again, or seeing raised eyebrows when you explain things. Um, or we just work together to figure out what might be the best way. Some systems allow patients now to have a bracelet as they go through that you can scan, that has all the information, so it doesn't have to be asked. But we still have trouble with phlebotomy. If the patient's biological sex is something, then their identity, sometimes when blood work goes to the lab, it comes back as inconclusive or in
Mhm.
error. So we still have ways to go with
Mhm.
other factions of, the cancer care system that need to catch up with this. I don't have the answers for
Yeah.
those, but just to prepare people that these things might happen.
Yeah, and I think that's at the bare minimum, that's what we need to do, especially if you're able to bond with a person who has not had a good experience in healthcare and get to the point where they actually trust what you're saying, will take your advice, and are willing to participate in the care that hopefully will lead to a life without cancer, or lead to early detection so that their cancer doesn't, you know, become a more aggressive issue than it could have been, right? So yes, I think preparing patients, if you're sending them for a mammogram, is important. The other things I do, Jay, you had mentioned earlier about cultural humility and how important that is. Patients have preferences, and I think in the SGM communities, there are people who they know not to go to. And then there are hospitals, even institutions they know are not welcoming. And engaging someone in that kind of conversations can also be very important. If a patient says, I absolutely do not want to see a male um, gynecologist, that's important things for us to know. The other step that I think I have taken recently is also to prepare not only the patient, but my colleagues. So it is worthwhile to do that phone call. I am sending you someone, you know, hasn't been involved in the healthcare system very long. She is coming in for her first mammogram.
Mhm.
And these are the things we need to be aware of. So please, watch for this and ensure that your staff is aware of that. It's not really, you know, making them feel separate. It's more about VIP levels of care that every single person that walks through our clinic deserve,
Mhm.
you know?
Yeah, and I think, setting the stage, finding out who their support persons are, not asking the traditional, like, are you married kind of question.
Mhm.
All of those things show that we care about you as a whole person. Like,
Mhm.
yes, you came in today to talk about blood pressure, but I want to take some time to get to know other things about you and to help you plan, for the future, what things that you can think about to improve your health as much as possible.
Yeah, I totally agree with you there. Yeah. So, I mean, I guess are there other issues that we should bring out from the encounter that we should chat with? Maybe where people are getting their information, for example. We're living in the wild, wild west where information no longer flows from our offices to patients. So we know that they're reading valid, relevant, and evidence-based literature. Now people can go on the internet, they can go into closed Facebook groups where biases are just further enforced by the stories and the studies that speak to the bias. How does one even begin to address that in the context of a single person sitting beside you like Stephanie was?
Yeah, I think that is so challenging because we don't want to insult people's intelligence. We don't want to say, well, you don't have a graduate degree in medicine, and so how could you possibly be able to read that study? It's sometimes hard for us to make sense of, even if we're reading the original source. And of course, that's what's happening a lot, is people are not reading the original source. They're reading the third, fourth, and fifth condensed version of it. It's challenging because we want to acknowledge that this person cares enough about their health to have done some research. And they may have even heard things from family members or loved ones or people that they trust. And we don't want to say, no, your mother's wrong. That's not true. So I think it has to be handled really gently. And what I tried to do in this case is assure Stephanie that this was a common misperception. It's not just a misperception she has, but one that many patients have in terms of which cancer screenings they qualify for or should have, and how often they should have them. So I'm curious if you have a different take on it, because I find it really challenging to gently kind of break down what can be a firmly held belief because someone read it on Facebook.
Yeah, I think it is a problem, particularly because sometimes the sources are ones they've always trusted. If they've always had this community on social media, their word means something because they may have had investments in this group that speak beyond just healthcare. What my approach has always been is to really try to, like you said, not come from a position of anger or judgment, but applying almost that lens of cultural humility, saying, oh, where did you read that? And do you know if they pointed to the place where they got that information? And then coming back down to, well, from the place that I sit in medicine, when I look at the information that has been published where colleagues of mine have actually said this is relevant and valid information, this is what that is telling me. And then I think just playing the card of a clinician, which is, as your doctor, my whole role is to provide you the best data that I have and guide you forward. So my recommendation is this, and I think you're right. At some point, autonomy has to be respected, and decisions. And I always see my place as, my role is to go towards delivering information so that the decisions that are made are evidence-based as much as they can be.
Mm-hmm. I think that's great advice.
So Dr. Quinn, I thought this was really helpful. It was certainly for me, and I hope everybody else feels it was helpful as well. Let's summarize in an actionable way the things that we discussed. Here are the SMART goals, SMART meaning to be specific and measurable, attainable, relevant, and timely. So we do want to collect gender data as well as sexual orientation. Again, together it's sexual orientation, gender identity, or SOGI. And we want to help to eliminate, or at least just even to identify, cis normative or heteronormative assumptions. so that we can communicate relevant information about cancer screening. That includes to SGM, sexual and gender minoritized people. And then in populations that we know have avoided or even delayed their medical care, we need to take the initiative to begin engaging them in their time and really under what they consider they are ready for. Remember, healthcare and our contacts with the patient are longitudinal. So there's a time for us to discover each other and develop that respect and rapport that comes with time. But we do need to recognize that everyone, including SGM people, need and should be encouraged to have routine medical care. And that does include promoting cancer screening. So with that, let me just thank Dr. Quinn for participating today and for your invaluable clinical insights.
Thank you. It was nice to work with you and to be a part of this.
And thank you to the audience for participating. We hope you found the information helpful and that you can apply it to patient care in your own practice. Just a note that you can visit the CME Outfitters Oncology Hub for free resources for healthcare providers and patients on this and other topics. To receive CME credit for this activity, participants must complete the post-test and evaluation online. Participants will be able to download and print their certificate immediately upon completion. Thank you again.